So I think we're going to get started now. Everybody settle down and we can have some silence in the room. I'd like to introduce our next session. The session is going to be coordinated and maybe chaired by Dr. Robert Mathenge. For those of you who don't know, Dr. Robert Mathenge gave a nice presentation on the history of interventional cardiology in Kenya as a keynote presentation at last year's Africa Stemi meeting. And this is because he was the pioneer of interventional cardiology. He did the first angioplasty here in 1997, 98? 1997. So I paid attention to that lecture. He's also the chair of Heart Attack Concern Kenya, and he'll be giving a short presentation at this evening's Song for the Heart concert. Without further ado, Dr. Robert Mathenge.
Thank you, Jaron, for that very kind introduction. I can see that we already lost a few minutes, so I hope that those people who are out there can be encouraged to come back very quickly. I want to quickly introduce Professor Tony Gashlik. Professor Tony Gashlik is not a stranger to East Africa, like he just told me. He did his elective in Tanzania years back, so welcome back again to Kenya. And he has come occasionally for a visit in Kenya, so in East Africa. So keep coming. And now he is a professor at the University of Leicester in the UK. His main activity is interventional cardiology, but has been involved in large stent trials, and he's been involved in ESC STEMI guidelines formulation. So here we have a very, very experienced person from whom we are going to learn and hear a lot. So without further ado, Professor Gashlik, please come over, tell us what has changed in the treatment of in the evolution of heart attacks, right from the days of James Herrick to today.
So, Robert, thank you very much, and I think all the organising committee, particularly the Kenyan guys, Harold and Robert, and particularly Mo, our old trainee, who's done really so well in this part of the world. So to give this talk is a real honour, particularly in the presence of such luminaries as Bernard Gersh and Tom and the other people, and it really is a great privilege. The last session I thought was absolutely fabulous, really interactive. So what I'm going to do is talk about STEMI Management 2017, where we are, where we were, where we are, and where we need to be. And I'm not going to talk about how it used to be, where patients were put in hot bed for 6 weeks, and the importance of the CCU. I think we know most of this. There's quite a lot to cover, so I think I'm going to restrict myself to a bit of background. The relative value of lysis, without impinging on Mpiko's talk a bit later on. You know, the importance of time, I heard this morning about the importance of time. And I can't emphasise enough, if you take one message away from the whole meeting, let alone this talk, it's the importance of time. And I'm going to do most of this. The other important principle is the evidence base. So we should practice our medicine, even especially perhaps our acute medicine, based on published evidence. I'll talk a bit about the pharmacoinvasive strategy, and where you're moving to is towards optimal primary PCI. And we've had a great session from the live case this morning, or case in the box, but I think some of those principles I want to give you the evidence base and try and establish what I think is the optimal primary PCI. And then finally, I'm going to talk a bit about the gaps in our knowledge and where our research opportunities are. So most of this is going to be based around these guidelines. You see these are the 2012 guidelines, and I was privileged to be part of this group. They take you to a fabulous chateau in the middle of France, the ESC, on a Friday afternoon. And they give you wine at 3 o'clock in the afternoon. It's absolutely wonderful. You think, this is absolutely fantastic. So pleased I said yes. And then about 4:30, they sit you down, all of you, and in our case gave us 675 papers and bits of data to review. And you're locked away for the next 3 days reviewing that data, and that's how you come up with the guidelines. You see hardly any wine, but just really data. So I'm going to refer to these because I think there are no Americans in the room, are there? Apart from Bernard. So I can say I think the ESC guidelines are far superior to the American guidelines. Bernard won't.
I actually agree.
So the open artery hypothesis is the critical thing. An open artery is better than a closed artery, and the flow, the TIMI flow, should be the same as that in the non-affected artery. Time is muscle. It's just about time, and we'll talk a bit about the timings as we go along. Permanent myocardial injury and its extent are predictors of poor outcome. This is the fundamentals of what we're trying to do. We want to make the myocardium as salvageable as possible. We go back to the 70s in a dog model where Reimer clearly showed that within about 40 minutes, myocardial cells start to become irreversibly damaged. And if you get to that point, then you're really only salvaging whatever you can get out of this particular model or indeed the patient. Here you see that that again you can apply this. The earlier you give the treatment, the better it is. And applying this to thrombolysis treatment, the importance of time is quite clear. The number of lives saved is really high in the first few hours, and then reduces significantly as you delay getting the artery open. So an open artery is really important, and you save most lives by doing things early. We talked a lot about that this morning, about how we get the patient to the reperfusion strategy, and I'm going to revisit that a little bit now. What we didn't say about the ECGs, of course, is it's incredibly easy to diagnose. This is not nuanced medicine. This is barn door stuff. You know, Paul's case, the ECG changed a bit, and was this, that, and the other. Turned out it had an occlusion of distal AV. That's not applicable to most. For most of the cases, you see this, and you know it's in a closed artery. In our hospital, the paramedics in our country, the paramedics make this decision, and the ECG is telemetried in, and then it's out of my hands. If this is what the nurses see, the Stemi team get called in. I don't have any say in this at all. That's because this is barn door ST segment elevation myocardial infarction, and it implies the vessel's closed and it needs opening. So we talked about the ECGs this morning. The important thing is, if you see an ECG like this, you know it needs opening. If you see T-wave inversion, bits of this and that and the other, it's not so relevant. It's important perhaps you do the angiogram, but this sort of ECG is where we really can have an impact. So that's good news. When you see that ECG, you see the occlusion of the coronary artery, and we know that this is obstructive plaque event with thrombus. The situation then is retrieval. This is not end STEMI, where you're trying to save myocardial infarction. This is about retrieval. This is about restoration of TIMI3 flow, and so salvage endangered myocytes. And of course, as we'll talk about, we all know, we have lysis or primary PCI. It's very simple. Someone this morning said this isn't very difficult. It's not difficult. ST segment elevation, you need to get the vessel open as soon as possible. Oh, I'm going backwards. I thought I was going forwards. Arrows are going the wrong way. So time's very important. What data is there? Well, there's lots of data to suggest that symptom to balloon time, shown in the left panel, or the door to balloon time, when you go beyond certain time metrics, you start to change the patient's mortality. This is old data, but it's worth reminding ourselves of just how important these data are. And what's interesting, this is from the Dutch group, and you could see, as I've arrowed here at the bottom, that every 30-minute delay represents an 8% excess mortality. That's something to keep in mind. Every 30-minute delay is an 8% excess mortality. So that's very important. So here are the times. We have these various symptoms to call, first medical contact, turnaround time TA, drive time to the door, initiation of reperfusion. Keep this in mind when you're thinking about the patient. We heard a lot from Kathleen this morning about telemetry, digital. It's important that sort of stuff doesn't confuse the issue. You know, it is important, and it may be that's what you need to get the best access and the best process. But this is what you need to keep in mind. You know, it may be better to have a network system in place than trying to individualize. General systems work better for the overall population, and that is the most important aspect of this. So what are these times? For us in the UK, well, first of all, the simple call time is about patient education. That's why there's a green circle there. There's nothing we can do anything about, other than complete education. Very important that the education is appropriate. The British Heart Foundation had a big campaign where they put out that if you've got a feeling of like a belt around your chest, you should call an ambulance and go to A&E. And they had this picture of this man who's obviously having a heart attack with a belt around his chest and say, if you feel like this good. And a patient in South London, I think it's your hospital, John, actually, turned up with his own belt around his chest as treatment. So the sort of education is really, really critical. I can't emphasise enough how important this green box is. It's always 105 minutes or whatever. So our arrival time, this is auditing. If you don't reach these metrics, then there's criticism both nationally and locally. So 8 minutes is the time for an ambulance has to take to get there. Turnaround time is about 20 minutes. The symptom to balloon time or device time has to be less than 150 minutes. This is what we work to. The door to lysis time is 30 minutes. But of course, as I've pointed out, taking the lysis, as David pointed out earlier on, taking the lysis to the patient is a huge time saving. In the UK, you know, we have traffic, we have Cumbria, we have Lincolnshire. These are big areas of distance. So how do you do it? Drones or motorbikes? Taking the therapy, the reperfusion therapy of the patient, saves significant time. And then, of course, the door to balloon time should be less than 90 days. Whatever you do in your complex environment here in East Africa and the whole of Africa, you have to keep this slide in mind. This is evidence-based. These are the things, if you achieve them, will help patient care. So we have a choice of thrombolysis or primary PCI. You'll know that Keeley and Grind published in 2003. I was the biggest critic of all of these data. But subsequent data proved it. The confidence intervals were very wide for many of the trials. They were old-fashioned streptokinase kinase rather than the TNK, etc. But it doesn't really matter. In 2003, this paper, benchmark paper, suggested primary PCI, all other things being equal, gives you better outcomes than thrombolysis. In the UK, we took that up. In 2008, I was part of this national angioplasty project where we decided. So we've been through what you're going through. We decided we were going to get a system, network system, that got the patient to primary PCI as soon as possible because of that data. And you know, we spent a lot of time and a lot of meetings with Department of Health trying to get this changed. And really quite quickly, we managed to change from lytic therapy being dominant therapy to PCI being the dominant therapy, because we were proactive about it. The sort of things I've been hearing about this morning. We were proactive. We went out, we engaged with people's stakeholders, we call them. And if you engage with your stakeholders, be it your legislature or your various hospitals or all the people involved, then you will end up turning things around. And indeed, this data from 2003 to 2013 from INAP is 84 hospitals trusts, 90,000 patients from 2003 to 2013. You can see the primary PCI rate, how it increased. Somewhat, I'm sorry that there's 3 screens, you can't see my pointer, but basically in some hospitals it went up very quickly, others took more time. But this was a very proactive. We engaged with the government. We said this is what's best for our patients and this is what we want to do. It went from 0.01% to 86.3% in a decade. We found out that primary PCI rates were lower for patients with previous myocardial infarction, heart failure, angina, chronic. These are the groups that we should concentrate on. Travel distances, age more than 80. We addressed that by making sure my oldest primary PCI patient was 101. Yeah, and she did well. There were downsides. So some PCI rates were higher in other patients. Trust with more than 5 interventional cardiologists, you need the resources, and 24/7. What that's led to is in the UK now, these are 2014 BSIS data, that 70% of hospitals provide 24/7 primary PCI. With system networks in place, and we're all audited for those times that I told you. We start to have our door to balloon time less, greater than 90 minutes, there's almost an inquest in our hospital. Well, there is an inquest, because they're so important. And the rest have sort of mixed models, we can talk about that. So what do you do if you can't achieve the mandated guideline times? I was privileged to be involved in the pharmacoinvasive strategy, which consists of, in my view, pre-hospital lysis, evidence-based adjunctive therapy, I'll show you in a second. Rescue PCA for failed lysis. So if the lysis failed, SGs haven't settled within 90 minutes, you go to the cath lab. And early angiography for even those with successful lysis. This next slide, I see it because it gives me a preview of the slide. It's complex, but it doesn't really matter. This is the Stemi trial that I was involved in with Paul Armstrong and Franz van der Werf. And you can see that it was patients who we felt could not get reliable primary PCI within 90 minutes. And they were randomised in the ambulance. So it's quite funny. The first one, the poor chap from Bristol, the ambulance driver, phoned it was run from Europe. And what they had to do was ring and get a randomisation number. So primary PCI or in hospital lysis, in ambulance lysis. And so the poor chap, he rang, and it was a European dialing tone. And of course, because he hadn't ever left Bristol, he thought it was engaged. So education is very important. Now, we lost our first patient because the ambulance guy thought, the paramedic thought it was engaged. Here you see our optimal lysis was, we changed it from less than 75 to more than 75. We halved the dose of TNK, we had no clopidogrel, we reduced the enoxaparin. And then at 90 minutes, if the ST had resolved, then we did an angiogram here within 6 to 24 hours, bottom left-hand panel. If not, then we went to rescue PCI. And that was compared in a large trial, in the STREAM trial, with primary PCI. This is much more relevant to you, when you're struggling to get primary PCI off the ground. I had already done the rescue, the REACT trial, which was rescue angioplasty versus not rescue angioplasty in failure of ST segment resolution, and shown that you needed to go to the cath lab and do rescue PCI. So that was part of it. And we published the STREAM trial again in New England, and you can see there was no significant difference between the two groups. What that says is if you can't get patients to primary PCI quickly enough, then pharmacoinvasive strategy is the right way to go. This is evidence-based. We talked in generalities early on about what's going on in this part of the world, and parts of Africa and India as well. But this is the reality of the evidence, and it's something that's worth considering. And certainly, this is included in the guidelines now, that if you have even successful lysis, then you go to coronary angiography. Now, I just want to make it a little bit more relevant to this part of the world, because whilst in Europe, so 7 million people die from coronary artery disease, and every 6th and 7th woman in Europe will die from myocardial infarction. You're not exempt, as we've already talked about. This is a growing burden of disease Mo talked about very early on. Whether it's 25% of 8% for? Whatever it is, it's there and it's growing. And I have an adage which says, a small percent of a big number is a very big number. So if it's 24% of the huge African population, then that's a big number. So it's an important point because it means that you have to do it properly. And this is the data that clearly shows, a slide that clearly shows you're not exempt from deaths from coronary artery disease. Not as bad as some parts of Eastern Europe, but certainly not as good as you would hope. And we saw some of this data earlier on. This is from Pretoria. 37% received fibrinolytic and only 3% medication within 1 hour. That needs to be worked upon because remember going back to the slides early on about time is muscle. It really is very important that you get the patient, forget everything else, you get the patient to reperfusion. And again, 45% of STEMI cases reportedly received fibrinolytic therapy in Cape Town and 30%, 6%. So we're getting there, but it needs more. And how do you do more? Well, I was very impressed by what Kathleen said earlier on about getting the evidence first. So if you're setting up a program for reperfusion, what you need to do is know what's happening. And what she did really well, eloquently, was tell us that what she was doing here in Nairobi was find out what's happening. So the first thing is to find out what's happening. And when I was in South Africa doing the sabbatical, we talked a lot, didn't we, about protocols. Protocols are really important because what protocols do is they take away individual decision making, and that's great. I don't get a choice about whether or not I see the patient comes in with a STEMI in the middle of the night. They come in. It's a protocol. I don't say, it's 83 years old and all that sort of stuff. Protocols take away individual decision making, and that's a good thing. Forget about your ego. Forget about whether or not you're the cardiologist and you've got to say whether they have this, that, or the other. If you have a protocol and you're signed up to a protocol, then it happens, and you're just part of it. We talked about this, didn't we, in Pico quite a lot in South Africa, having protocols. This slide was made like a week ago. Formal public education, use smartphones. How predictive this morning was that when I said use smartphones? Protocols are very important, networks, and involving stakeholders. If you do this, forget all the rest of the faff around it, all the thinking, all the nuancing, then patients will benefit, in my view. So what does the World Health estimates that NCDs will exceed communicable diseases, leading cause of death in Africa in 2030. So the epidemic is coming your way. So, mixed strategy. For this part of the world and for the UK, I think there should be a mixed strategy. I don't care what you do. If I was organising, I don't care what you do. I don't give you pre-hospital lysis, in-hospital lysis, pharmacoinvasive strategy, or primary PCI. We know primary PCI is best. If you can't do that, you still do the very best to get your patient to the reperfusion strategy as soon as possible. Time is muscle. Ischemia time is very important. Door to balloon time, if when we talked earlier on about, Kathleen showed, I think, a transfer, bypassing 2 or 3 primary PCI hospital, PCI capable hospital, going to a non-PCI capable hospital. That doesn't happen in the UK. We forget about the egos of the non-invasive hospitals. We take the patient to the primary PCI centre. And having heart centres may be one of the ways around it. I'm dabbling in things I don't know anything about, but having systems that allow the patient to get the best treatment is very important. So, symptom to balloon time. If I had a door to balloon time of 20 minutes, but the patient spent 4 hours getting to me, that's nonsense. It is the ischemia time that's so important. These are the guidelines. Primary PCI is recommended, and it's a one-way. I have to say, I wrote to Bernie about this article in Heart, and even, I'm going to say this is a common criticism of the UK, when I did the pharmacoinvasive strategy stream, all the people on NIAC that I've been involved with gave me a really hard time. John may have been one of them actually. But they used to stand up and they used to queue up. Roger Boyle and Hugh and Gray and all the Department of Health people saying, stop confusing the issue with pharmacoinvasive drugs, you just do primary PCI. Well, look at this, they've just published this. And they said that the median core to balloon time, remember that it's the ischemia time, that's all we're interested in. We're not interested in the door to balloon time, it's ischemia time. And door to balloon times are 101 and 41 minutes respectively. That's very good. 80% patient treated in 150 minutes call for help. That's they're proud of, but that tells me that 20% were not treated within the mandated guideline. Inter-hospital transfers take up a lot of time. So don't take the patient to a hospital that can't give the reperfusion therapy. And importantly, the core to balloon time in red was independently associated with 30-day mortality. So the UK, for me, I can say this because none of them are here, apart from John, who won't tell me. I think didn't listen to me. They went primary PCI, but everyone's going primary PCI. And that was good because it established primary PCI. What I kept saying to them is that 20%, I actually used the word 20%, of the population won't be able to get to the mandated guideline times. And so it turns out 20% of the population don't reach the core to balloon time. And they have worse outcomes. So I really, really, really try and encourage you to use mixed models, but the timing is important. So for the last 10 minutes or so, I'm going to talk about optimal primary PCI. I still do on-call. I was on-call, I think, Tuesday night. 2 calls, I call out in the middle of the night. It keeps you around, apparently, although we feel absent. It's a very funny thing doing primary PCI. Who does primary PCI in the middle of the night? Yeah. Okay, so it's a funny thing, isn't it? Because you wake up, you try and stay asleep in the car, drive to the hospital, listen to the radio, and then there's no way you can stay asleep during the case. And you're really grumpy about getting called in. And then you do the case, and a lady, I think on Tuesday night, gross ST elevation, mid-70s, anteriorly, you can put a wire through, and the ST starts to settle. Direct stented, and the ST settled. She said, you've done something. And that feeling you get back in the car to go home, one, you can't sleep because you're now buzzing, but that feeling you get that you've actually opened an artery. And some of the, with respect to Bernie's and non-interventionists and the other non-interventionists, there are lesions, there are occlusions that you just, thrombolysis will never work in these. It just will never work. Thrombolysis has to get to the actual thrombus. And I think it's a very satisfying and I think a very valuable thing to do. We've got to do it properly. So I'm going to talk about what I think is optimal. We had a great talk from Paul and a great case highlighting all of this, but I'm going to give you the evidence. So, procedural aspects of primary PCI, you should be doing stenting. Yeah, there was some business at some stage about getting TIMI 3 flow and bringing the patient back from microvascular obstruction. You should be doing stenting and direct stenting when you can. So stenting keeps the vessel open. It's really important. We talked a bit about culprit. Current guidelines suggest 2AB. Tomorrow I'll talk, or maybe later on today, with a bit less time than this, I'll talk about my views on culprit versus not. Radial, got to be radial. Just got to be radial. I mean, it's so encouraging to see that most of the interventions are doing radial. It does make a difference, but your juniors have to be able to do femoral. A number of times I've gone in the lab, not very often, but often enough, gone in and I see them struggling, taking little balloons up and wires and spasm and all of that. And really, I just go in and I do direct femoral. So you have to train your juniors and to do this. Routine thrombus aspirations should be considered. These are the 2012 guidelines that I was part of. Why do radials? Because, it's horrible to have a femoral complication. And the nurses on the wards hate femorals because patients can't mobilise. We have patients who come up from our cath in their clothes. I was really shocked the other day. They come in their clothes and they get on the table, we do a radial, they get back in the chair, go home. I mean, it really is. Tony Rickards is one of the godfathers of angioplasty. He used to say we should take angio, make it as patient-friendly as possible, and take it to the patient. And he was absolutely right. But there are data out there. There's MACE from many meta-analyses and you can see overall MACE favours radial to the left line of unity, and even mortality again here to the left bottom panel of the line of unity favours. And that's because bleeding is an important factor in mortality. Who said this morning something about giving lytics and powerful? Even us, we give power. If we don't give lytics, we give prasugrel and aspirin. In little ladies, you get complications. And in the UK, this is again BC's data. You can see that currently, until 2014, 75%. You cannot do a case, a PCI in the UK, without it going into the BC's data set. It's a bit bean counting, it's not very sophisticated, but every single case, if you put case in, if you do a case and it doesn't go in, it gets reported to a chief executive. So every case, so these are reliable data. And you can see it's 75% radius in 2014 for all comers, but particularly for... Now, we talked about thrombus aspiration. Again, I'm just going to talk about it very quickly. It's so lovely, isn't it, when you get this? The ambulance crews love it. I always bring the ambulance crews into the back of the cath lab because I think that engages with them and they see the result and they can see what good they've done in bringing the patient to the cath lab. So the next patient they'll bring straight to us. And when you see, these are all bits that I've got out of coronary arteries, and it's fabulous because, it's practical, it's there. But as we heard, I was also privileged to be part of this trial of Sanjit Jolly, the total trial. And I think the important aspect of this was that you can see that it made no difference. Now, people get confused because this was routine thrombus aspiration. That's what the trial said. And everyone got confused and thought we shouldn't do thrombus aspiration. 2 weeks ago, 48-year-old man, right coronary artery, left coronary system normal, check the left first, of course. Right coronary artery just packed with thrombus. Plaque event, had a thrombotic response to probably a minor plaque event, smoker or hyperlipidemia. You don't have to have severe stenosis to have thrombotic occlusion. Had a prothrombotic response to a minor plaque event, packed with thrombus. Now, and also had some pruning distally in the posterior descending. So I aspirated, because total did tell me that I shouldn't do that. But when I aspirated, as pointed out by David earlier on, as I pulled the aspiration catheter back, I engaged the right guide catheter, because if you don't, there's a risk of stroke. And there was an excess risk of stroke in these data. So doing it properly is very important, but you can do it. Just because total and TASTE said no for routine, that doesn't mean you shouldn't stay. So again, for the last 5 minutes or so, 5-10 minutes, I'm just going to talk about major gaps in evidence and where we're going, and what I think are the real ways forward. These are from the European guidelines. I've been a referee for the new guidelines, and they're not dissimilar. The same sorts of gaps in the evidence over the last 5 years hasn't really changed. You can see here all the things we've talked about during this fantastic course: optimising clinical pathways, improving public and patient awareness of Stemi symptoms. We go to the rugby ground, the Tigers, and people come on and demonstrate CPR on these models. And it's good because there are people in the audience who may do it. And what it has led to is a lot more out-of-hospital arrest coming in. So we see a lot of out-of-hospital arrest because people are doing CPR in the shopping malls. Reducing myocardial injury, optimal management, non-culprit, and various other things. I'm going to talk about some of these things. The reason is because we still have a 12 or 15% mortality at 1 year from Stemi. And this is from Stephen James, that's really unacceptable. We should be doing better than that, even with optimal management. These are the things I think are important, and I'm going to talk about perhaps with 2 slides each. Pharmacoinvasive strategy, we talked about, I put it in orange. Thrombectomy, routine thrombectomy, I put in red. But the areas that I think are really important are, just playing animation. Okay. Infarct artery, all or none, I'll talk about that later. Microvascular obstruction, cardiogenic shock, I think is a really important issue, and reperfusion injury. So here's two patients from Culprit, and you can see in the left panel is an occluded LAD and a really tight right coronary artery. Who in the audience intervention would do that right coronary artery? Yeah. And on the left you see an included, on the right you see an included right coronary artery, the lesion in the LAD, both with Culprit. And you can see these were the results in Culprit, significant, small trial, no doubt, but significant difference in outcome for doing it all versus just doing the Culprit intervention. And we've done a number of meta-analyses, and all these seem to show that all-cause mortality, cardiac mortality, re-AMI and revascularization are benefited. But we can talk about that a bit later on. Microvascular obstruction, the unseen. We're not talking about no reflow here. We're talking about microvascular obstruction. John's going to talk later on about MVO or CMR and how you diagnose it. But there's no doubts that if you have TIMI 3 flow and poor flow distally through TIMI blush grade, your outcomes are much worse. So microvascular obstruction is very important. Again, we did the reflow Stemi trial. We compared adenosine with SMP, given intracoronary in 2 doses, and unfortunately, we found that there was no difference at all. And our conclusions were that intracoronary adenosine and SMP did not reduce infarct size, and high-dose adenosine appeared to be associated with adverse clinical outcomes. There are trials ongoing. This is the T-time trial, where you give thrombolysis in the context of primary PCI in order to reduce this microvascular obstruction. And the big trial, European €6 million Euro strategy, where we're involved in trying to give various treatments, intensive treatments, to reduce what we think is very important, which is microvascular obstruction. That's Euro strategy. Just a couple of slides on cardiogenic shock. It has worse outcomes than some cancers. There are cancers that don't have a mortality of 50% at 6 months. It happens in 6 to 12% of all acute coronary syndromes, and it's going up. It's going up because of CPR, because of intervention. This is a shocking slide. This is the mortality for ACS with and without cardiogenic shock. With cardiogenic shock, blue line. Without cardiogenic shock, red line. What a difference. If there isn't a place for dealing with cardiogenic shock in our strategies for research, then I'd be absolutely surprised. If you're not doing this sort of intervention, it's coming your way. Cardiogenic shock is a real problem. And it happens early. So if you can do something early, this is some data we published from BESIS, if you can do something early, then all this line is reduced. Do something early, you impact on late outcomes. It's not an exponentially increasing. Revascularization is important. Drugs don't seem to work. This is a NOS inhibitor. Maybe there's a role for devices, not intra-aortic balloon pump, that's been shown not to work, but maybe ECMO and impeller. And again, we just put in, literally took up every moment of my life for the last 4 months, a €6 million intervention trial for the European Horizons 20 Euro shot. This is a complex slide. Luckily, I'm not going to talk about it, but the ischemia reperfusion injury is a very important issue. Trying to salvage these myocardium that you've intervened on. And unfortunately, drugs like cyclosporins you've shown here do not work. So this is my final slide. I think this is Bernie. Is this your slide in the middle? Yeah. So Bernie needs to be congratulated, as always, for developing this slide and talking about time is muscle. And, you know, the sooner you can go from, if it works, it'll be fantastic. Sooner you can go from what was an occlusion on the left to a completely open artery on the right, the better. No question about it. Time is all. Do whatever you like. Primary PCI if you can get it going, lysis, pharmacoinvasive strategy, or mixed. But whatever you do, do it well. Use evidence-based practice, sort of things I've talked to. Questions about complete versus infarct-related artery, MVO, cardiogenic shock, ischemia reperfusion injury, and length of dual antiplatelet therapy. So the lights have gone down, which means you can all wake up without me noticing. Actually, I want to say thank you again to all the organisers for giving me this chance to share my journey through intervention and reperfusion, and I'd hope to come back again and see the fabulous progress you continue to make. Thank you very much. Oh. You could say that again. You could say that again. Say here?
No. Oh, I must say that we must all be
Really? Oh. Thank you very much, Professor Tony Gashi, for that wonderful lecture. We have benefited from your experience.
Yes. We cannot have asked for a more experienced person. You've seen management of heart attacks evolve over your career, and now we know where we are. And here in this region, or of course in Africa, our challenges, of course, as you know, and we put them very clearly, are slightly different. In a country like Kenya, where you've only 8 cath labs, all in one region. In Africa, where most countries don't even have a single cath lab, it is really, we are glad that you are able to give us some guidelines as to how this can be done, how the state of care is there. We have the state of care, the art, but how do we spread it to the people in the continent who are now getting very threatened by this new condition? And you alluded to it here very, very carefully, and we are going to develop on that. I would emphasize that you talked about the non-involvement of the cardiologist, meaning the protocols. You emphasized on the protocols. And somebody mentioned that earlier, I think it was Dr. Wachira, that with protocols you can have things happen far away, because our challenge is how do we serve in Kenya 48 million when the best treatment is only available here. So we have had you open the artery as early as possible, develop protocols that can be used by people who don't require a lot of years and years of training, and of course, be able to offer the therapy that will require minimum capital investment, because that's the only way that is possible in a resource challenged environment like in Africa. Again, Professor, thank you very much, and we look forward to seeing you again next year and in the future. Thank you. I will now hand over to the next person to come over and take on the next session. Thank you very much. Thank you.
Thank you. Thank you very much for that wonderful talk. Next